Hello, good morning, and my presentation is about amphotericin B. Our learning objectives are to describe the mechanism of amphotericin B, recognize important adverse effects of amphotericin B, and describe key differences between amphotericin B formulations. And number 4, create the optimal treatment plan to prevent toxicity. So amphotericin B is an antifungal agent produced by the soil acetomycete, specifically from Streptomyces nodosus. It's FDA approved in 1959. It's insoluble in saline and mixed with sodium deoxycholate. The mechanism of action is preferential binding to ergosterol of the fungal cell wall, leading to the formation of pores or holes that leads to efflux of potassium and magnesium. Through the efflux of these electrolytes, there's an influx of protons, leading to the acidification of fungal interiors. And this leads to the precipitation of cell wall, leading to cell death. The spectrum of activity is very broad, which includes cryptococcal species, invasive aspergillus, candidiasis, leishmaniasis, histoplasmosis, and mucormycosis. The adverse effects include nephrotoxicity, infusion site reactions, and electrolyte imbalances. Some infusion site reactions include fever, chills, rigors, nausea and vomiting, and headache. Some electrolyte imbalances include low sodium, low potassium, and low magnesium. Conventional amphotericin B was the first to be approved, and it's called fungizone. Upon IV infusion, this type of amphotericin B separates from deoxycholate, and 95 to 99% are bound to plasma lipoproteins, such as HDL and LDL. Moving on, the newer formulations are the lipid-based amphotericin Bs. There are actually 3 types of lipid-based amphotericin B: liposomal, lipid complex, and the last one, Amphotech, is no longer available in the US, so we're not going to talk about it. The benefits are it's easily prepared since it's a liquid lipid formulation. There's a lipid bilayer that protects the drug from destruction and leakage. Liposomes prevents diversion of this drug to vulnerable tissue, such as the kidneys. And there's a sustained release as it's associated with the carrier. And eventually there's an uptake by mononuclear phagocyte systems, which introduce this medication to the desired site of infection and increases its efficacy. The mechanism of action in the picture form is the lipid-based amphotericin B is still administered IV, but the amphotericin B is uptaken by the reticular endothelial system, which leads to the eventual slow release from the macrophage complexes to free amphotericin B. This leads to a lower peak levels of free amphotericin B. As a result, less nephrotoxicity. Pharmacokinetic comparison-wise, amphotericin B, lipid amphotericin B is larger due to the lipid components, and there are different ratios of lipid and amphotericin B, and as a result, they are not interchanged. So there's different doses given. Now, there are some important nephrotoxic literature describing which amphotericin formulation to use. The first one from Fauci and colleagues, he saw 431 patients, and there were 3 different interventions compared. liposomal amphotericin B, lipid complex amphotericin B, and the conventional amphotericin B. And he found that the liposomal amphotericin B was associated with better outcomes in severe nephrotoxicity and mortality. As a result, liposomal amphotericin B is the preferred regimen. Moving on, Germania and colleagues found in a prospective study that hydration of 1 liter of 0.9% normal saline daily and electrolyte supportive care led to 71% of patients had no dose-limiting adverse effects. And for comparison, usually in some studies, depending on which study you read, patients taking regular amphotericin B usually get 50%. About 50% of the patient population will eventually have some sort of nephrotoxicity. So the author concluded that about 1,500 milliliters per meter square of body surface hydration and electrolyte supplementation can contain nephrotoxicity. And on a side note, just for reference and clarification, in this study, every patient received the standard conventional amphotericin B. So there is a question of whether we could extrapolate this result to liposomal amphotericin B. And lastly, the newest trial, Toshiro, in his observational study of 90 patients of people who develop AKI after receiving liposomal amphotericin B. I want to make sure everyone understands that this is liposomal amphotericin B, that liberal fluid management and conservative fluid management both led to positive AKI recovery. So what does liberal fluid management even mean? Well, liberal fluid management means that before the AKI, the patient were hydrated with 1 liter of normal saline. And conservative management is they only obtain hydration after the AKI was discovered. The mechanism of hydration. There is a lack of evidence in hydration for liposomal amphotericin B. But as discussed in the previous Jeremy and colleagues study, there is evidence for conventional amphotericin B and hydration. And as we all know by now, liposomal amphotericin B is still clear and still does accumulate in the kidneys. So I believe the thought process is that hydration will still yield beneficial effects. And I don't believe anyone will be willing to do a randomized controlled trial to compare liposomal amphotericin B with or without hydration, because it's pretty much unethical since we already know the toxic effects of amphotericin B. I think the thought process overall is to, of course, decrease exposure of amphotericin B to kidneys by removing amphotericin B through the urine. The more you drink, the more you urinate. And of course, the lack of saline or salt is thought to lead to amphotericin B accumulation in the kidneys. And that is why that normal saline is recommended instead of something like dextrose 5%. So moving on to prevention of adverse effects. So you'll of course want a lipid-based formulation. Now there are still some question marks about liposomal versus lipid complex, but the current literature does suggest that liposomal may be superior, although that is still pretty much up in the air. Of course, we need hydration and electrolyte supplementation as indicated. So pre and post hydration with normal saline, 500 to 1,000 milliliters is usually the recommendation, and it's the recommendation used in the study. You should, of course, aim for 1,000 milliliters, but of course, you could use 500 if the patient is volume overloaded. And pre-medication wise, it's of course only necessary when patient had a non-anaphylactoid reaction. Because if they had an anaphylactoid reaction, you would straight up discontinue amphotericin B. Of course, you could use 1 dose of acetaminophen plus diphenhydramine, and of course, meperidine for rigors as needed. So what are the take-home points? Take-home points are the major side effects of amphotericin B is nephrotoxicity and infusion reactions. Liposomal amphotericin B has significantly lower nephrotoxicity compared to conventional amphotericin B. And there are benefits pre and post hydration with normal saline for patients receiving amphotericin B.